Ladies and gentlemen, thank you so much for the opportunity to present on a topic that I feel very passionate about, namely hepatitis C in children, from Nobel Prize to cure. So I'm Karen Murray. It is my honor to be here. I am representing Cleveland Clinic Children's and, of course, was past president of NASPGHAN, and it's my absolute honor to be presenting at the NASPGHAN meeting this year. So again, thank you very much to the organizers for this opportunity. I do not have much to disclose, but I do receive research and consulting support from Gilead and consulting arrangements with Alberio Pharmaceuticals. So my objectives today are to assure that by the end of this hour, you will have an appreciation for the advancements that have been made over just a few decades in the area of hepatitis C through research. I hope that you will have full comprehension of the epidemiology of hepatitis C and recognize how to diagnose hepatitis C in children and the significance of a positive antibody against hepatitis C. Additionally, it is my hope that you will be able to identify early treatment options for those children who end up being chronically infected with this virus. So to understand what has happened over the last decades in the advancements of hepatitis C, we must really understand the history of viral hepatitis and its discoveries. So if we go back to the late 1800s, 1885 to be exact, there were two outbreaks of what at the time was described as catarrhal jaundice, or jaundice thought to be of an infectious origin and transmitted through human serum. And it was at this time that there was really gaining an understanding of viral transmission of illnesses that fell in the realm of hepatitis. However, it was during World War II era, 1947 plus or minus, that human volunteers really enabled the distinction of two different filterable agents for hepatitis C, for hepatitis. And these were termed hepatitis A and hepatitis B. And they were really distinguished through two different presentations of similar symptomatology, but one that appeared to be transmitted enterally and one that appeared to be transmitted parenterally, in both cases leading to classic hepatitis symptoms of jaundice, malaise, etc. In 1965, the Australia antigen was discovered. This later was known to be hepatitis B surface antigen. But it was not until a few years later that Baruch Blumberg identified hepatitis B as the cause of this form of hepatitis. And it was approximately a decade later, in 1976, that he received the Nobel Prize for the discovery of hepatitis B. So in 1979, a few years after the Nobel Prize, the other filterable agent of hepatitis, of the hepatitis A and B, was discovered, and hepatitis A was isolated. So by the time we enter the 1980s, although there were clearly a number of distinguishing discoveries and things noteworthy about the 1980s, we were left with what appeared to be a blood transmittable agent causing hepatitis, and this was termed non-A, non-B hepatitis at that time. Now, at about the same time, in the 1970s to 1980s, Dr. Harvey Alter was working at the NIH, National Institute of Health here in the United States. And as a clinician, he was noticing that there were patients who were getting ill with hepatitis, what in the 80s was now termed non-A, non-B hepatitis, after blood transfusions. And as a scientist and a clinician, he started documenting in a detailed way the features of the clinical presentation and what the risk factors for these individuals might have been. He also started collecting and creating a biobank of samples of individuals who got sick with this, as at the time, ill-defined non-A, non-B hepatitis. He did, however, with one of his biobank samples, note that he could take a sample of blood from one of the ill individuals and give it to a healthy chimpanzee, and that chimpanzee would go on to develop the same illness, suggesting that this was a transmissible agent, much like a virus. Later in that same decade, around 1988, Dr. Michael Houghton had just recently joined a new company, and using techniques that were new at that time, was able to isolate fragments of viral genetic material from infected chimpanzees. And in utilizing antibodies from patients who similarly were ill with the same illness, was able to isolate proteins. And through this, he began developing the theory that this was a flaviviridae form of a viral agent. And ultimately, the viral genome could be coded. And he was credited with really identifying hepatitis C as this flaviviridae. Approximately a decade later, Dr. Charles Rice was very interested in the same virus, but he used techniques to clone de novo the hepatitis C genome. And then using this cloned, not isolated, but cloned and created genome, was able to infect with this genome uninfected chimpanzees, and they developed the same illness. Really validating and verifying that it was this genome, and specifically this virus, now known as hepatitis C, for which this illness was credited. And we might recall that after Dr. Houghton's discoveries, the ability to detect hepatitis C in blood banks was created, and that was in 1992 when our blood could be screened. And in 1997, through Dr. Rice's discoveries, we now have firm knowledge that this was hepatitis C. We could now screen our blood for it, and we could keep our populations safe. And it is through the work of all three of these individuals approaching this from different directions that they received this past year the Nobel Prize for the discoveries and the work that have led to really curing lives now from hepatitis C. So where are we now with hepatitis C? Well, unfortunately, it continues to be a global problem, but thanks to the 3 Nobel laureates, a cure is now a reality. So hepatitis C is estimated to infect approximately 72 million individuals worldwide. As you can see, country to country, there are differences in the prevalence of this infection. And in South America, as well as North America in general, we enjoy relatively low prevalence rates to this infection, but other parts of the world are much more seriously infected. In the United States, we believe that approximately 1.7% of our population has anti-hepatitis C antibody from prior infection or ongoing infection, and that's about 4 million individuals. And of those, approximately 2.4 million, or 1%, are actually infected. Now, worldwide, in children, it's estimated that approximately 3 million children are infected. And again, there is some variation country to country, with South and Central and North America being relatively low prevalence. How do these individuals get infected? Well, we know in adults, by far, the most common way of infection is through intranasal drug use or other parenteral exposure to drug use. But there are also mechanisms of infection of lower rates of infection. This drug use is very important, however, because drug use tends to predominantly infect a younger adult population. And in fact, the cases of acute hepatitis C have been going up in this younger population in general. So 30s to 40s and 20s predominantly. And if we look at overall new cases of hepatitis C, again, it tends to be in younger adults. And as we might predict, unfortunately, the growing number of young adults infected means that there is a growing number of women of childbearing age infected, and this could very well increase the number of infected babies. And in fact, as we look at the number of babies that are born with perinatal infection of hepatitis C, this has been paralleling the opioid epidemic and the rates in children. In young women. So there are some other factors, however, that are important in informing how transmittable the virus is vertically, or what we call vertical transmission. The degree of hepatitis C viremia, whether they are the adult is co-infected with HIV. Are they drug users? What about the obstetrical procedures, specifically invasive monitoring with scalp electrodes and prolonged rupture of membranes can increase the likelihood of vertical transmission. We do know that the mode of delivery itself and whether an individual breastfeeds is not directly related. However, we generally recommending women with cracked nipples because of blood transmission to abstain during that time from breastfeeding. So hepatitis C prevalence in children, we know to be largely driven by that in adults. And we know that most children who are infected have become infected via the vertical route. We know that the prevalence of women of childbearing age is the strongest predictor of young children being infected. And the proportion of hepatitis C in adults who use injection drugs is significantly associated with the prevalence in our teenage children. So vertical transmission accounts for at least 60% in most studies of infected children. If we look overall at children, approximately 5% of infants born to infected mothers, those who are HCV RNA positive, will become infected with the virus. However, spontaneous clearance of hepatitis C does occur in young children. And we specifically know that about 25 to 40% of infants will clear the virus by ages 2 to 3 years of age. Approximately 11% of infants who are infected by donated blood and 30 to 40% through contaminated blood products, when that was still an issue, will spontaneously clear the infection. As children age, however, the likelihood of spontaneous clearance does decrease. And we know that approximately 6 to 12% of children will clear the virus up to about age 7, and then that likelihood decreases thereafter. So what if an individual is infected? This is a typical timeline of the antibodies and transaminase elevations to an individual who becomes infected over a timeline. So on the x-axis is time in months and then years after perinatal exposure. As you can see by the dotted line that is decreasing, the maternal antibody is passively high in the infant, but then wanes with time. By the Y dotted line, in infants who remain infected, they will develop their own antibody, and that will ascend with time, typically becoming detectable sometime in the month to year after birth. In those individuals who are in fact infected, RNA can be detected somewhere between 1 and 2 months of age and will then remain persistent during their time of infection. And their ALT level will wax and wane, and elevation tends to be mildly elevated in children, although it may be more elevated earlier on, and that is denoted by the wiggly line of ALT over time. There are some factors that are more associated with spontaneous clearance in infancy. Genotype 3, and I will describe genotype shortly, is more likely to be spontaneously cleared. In infants that have a higher ALT in the first 2 years of life, in other words, more immune activity, they tend to clear the virus more. And those that have a favorable IL-28B, what is now INFL3, single nucleotide polymorphism, tend to spontaneously clear the virus at a higher likelihood. But that said, still approximately 85% of individuals overall who become infected remain infected. So how do we screen for this infection? Well, there are two sort of high-level categories for screening. One are antibody tests and the other RNA. So for antibody tests, so the antibody against hepatitis C in individuals who we believe might be infected because of their high risk or elevated ALT, there's a very high sensitivity and specificity that these are excellent in detecting the virus. However, for those individuals who are lower risk, the example would be blood donors. The sensitivity and specificity tends to be lower, approximately 50 to 60%. Antibody can be used in the acute setting after approximately 2 months of infection. If we are looking at an earlier time frame, anytime after 2 weeks, or if an individual is antibody positive and we want to validate that they are infected, then an RNA test must be used, testing for the genome itself. It is also a very useful technique in situations where there may be low antibody production, such as immunosuppression of multiple causes. There are two general categories of RNA. One is qualitative, giving you a positive, negative result. The other quantitative, which will actually give you an absolute level. Most tests lately have a very low threshold for detection and are still able to give you a quantitative result. Most labs have now pivoted to quantitative assays for this reason. And then lastly, we can look at the variants of the genotype through genotype testing, and I will explain this again in a moment. So what is our typical algorithm for screening and verifying infection if positive? So we start with an antibody test most commonly, and the American Academy of Pediatrics does recommend screening children at 18 months of age with a hepatitis C antibody. If that antibody is negative, that suggests there is no hepatitis C detectable and you do not have to continue any further evaluation. If, on the other hand, the antibody is positive, then we must validate whether the individual is infected or they were previously exposed, and we do that with an RNA test. If the RNA is negative, that would suggest that there is not an infection. However, it is generally recommended that the RNA be repeated approximately 6 months later to validate that it is in fact clear. If it is still negative, no further testing is required. If, on the other hand, the RNA is positive, then that individual is infected with the hepatitis C virus and appropriate referrals are indicated. Now let's talk a moment about genotypes. So genotypes are created when the viral genome mutates. So this is a cartoon depiction of the hepatitis C genome. And there are areas within this genome, specifically the envelope and hypervariable regions, where there tends to be a lot of spontaneous mutations. The hepatitis C, as you can see depicted on the far right side, has its own RNA-dependent RNA polymerase. And it is through this polymerase that these mutations are detected, and generally corrections are made. However, in the case of hepatitis C, the RNA polymerase lacks very good proofreading. And so you end up getting genetic variability. And this is a depiction of the genetic variability that tends to have geographical distribution. And these are called genotypes. And our phylogenetic analysis has revealed that there are 7 genotypes, and they can be subtyped into over 70 subtypes. And these are all hepatitis C with stereotypical genetic variation in these various categories. Why do we care about this? Well, these tend to distribute themselves in geographical areas, and you can see how that's depicted here. In the United States, we tend to have a predominance of genotype 1 with lower prevalences of genotype 2 and 3. But as you can see in parts of Central and South America, there tends to be even higher rates of genotype 1 with other genotypes of variable prevalences. However, these genotypes portend different responses to therapies, as well as how they progress histologically. So genotype 1, for instance, tends to have higher RNA levels, tends to be less responsive to interferon, and tends to portend a more severe disease. Genotype 1 and 4 tends to be more associated with insulin resistance, and genotype 3 tends to have a bit more steatosis on histology. This is also important as we look at therapies, and you will see some distinctions in our therapy effectiveness with these different genotypes. So in 2020, the U.S. Preventative Services Task Force looked at and made recommendations on screening individuals, adults and adolescents with hepatitis C. And they recommended that screening for hepatitis C should be done at least once in all adults over the age of 18, including with every pregnancy. However, both the American Association for the Study of Liver Disease, as well as the Infectious Disease Society of America, recommends one-time testing of all persons, including those younger than 18 years of age, especially those who are at risk for hepatitis C exposure. And we know through cost analysis that the routine testing globally for all individuals with hepatitis C is cost effective and therefore is recommended. So if a child gets infected with hepatitis C, what is the impact on this? Well, let's first look at this from a histological perspective. So these are studies all in the histological impact of hepatitis C on children. And I specifically want to point out that most children have lesser inflammatory impact on the liver than is typically seen in adults. But I will also point out that if you look at these studies, many of them show some variability, but approximately 2%, some as high as 8% of cirrhosis in most series. So although the impact, in fact, may be lower than in adults, it is certainly not benign in all patients. We also know that a few studies have shown increasing impact with duration of infection. And for some, this also then suggests that as our children age, and they may have their courses complicated by other features such as obesity, which is becoming more prevalent in a lot of Latin America and certainly is already in North America, they may suffer additional insults to their liver. And consequently, we really must take this infection seriously for children. Now, most children infected are asymptomatic, and extrahepatic manifestations are really quite rare, as they are in adults as well. However, most have intermittent, sometimes persistent, mild ALT elevation. But unlike hepatitis B, there's no correlation with ALT elevation and histological severity. And we know that children who have normal or only mild elevations of ALT or intermittent elevations can still succumb to worsening histological advancement. Some series have shown approximately a 10% rate of hepatomegaly. This tends to be correlated with higher rates of ALT. So factors associated with more severe clinical disease, as we might expect, are also factors that tend to bring additional insults to the liver, namely obesity, history of childhood cancers and therefore chemotherapy or radiation exposure, congenital anemias requiring transfusions that may lead to increased iron overload, co-infections with hepatitis B or HIV, intravenous drug use or alcohol use that brings additional toxin strain to the liver, and homelessness or incarcerated youth because they frequently have alcohol and some of these other co-infections with them during this incarceration or homelessness. But there are impacts beyond hepatic that we do have to consider. We know that chronic hepatitis C impacts adults strongly with decrements in quality of life, cognitive performance, specifically attention and higher executive functioning in comparison to healthy controls. And anxiety and depression in adults is very severely affected when they are infected with hepatitis C. As many studies have now been done in children, we find similar types of impact. Specifically, we know that of children who are chronically infected, approximately 20% will have impairment to executive function. This is ability to self-regulate and attention. Children with hepatitis C tend to have overall worse cognitive functioning, and parents and families tend to have increasing concern about their children's health in a way that actually affects family functioning. So chronic hepatitis C not only affects the liver, but also affects our well-being and our ability to function intellectually. So if someone is infected, we really do want to be able to avail them of curative treatments if the benefit-risk ratio is in their favor. So let's switch gears and talk about the advances that have now occurred in hepatitis C in children. Back in the late 1900s, interferon and then interferon and ribavirin were the therapies that we had available. And we were thrilled to have them because they led to sustained virological responses of approximately 30%, which was a huge advancement to having no therapies at all. They had very significant treatment consequences and side effects, however, so we had to weigh the benefits and the risks to these therapies. And we advanced into the 2000s, 2011. We were able to benefit from advances in the interferons to now have pegylated interferon and ribavirin. And this now increased our sustained virologic response after therapy to 50 plus. And in favorable genotypes, such as genotype 2 and 3, it was as high as 80%. We continued to struggle with significant side effects, but now we were able to cure this infection in at least 50%. But now you fast forward another decade, 2 decades, and we have available a cornucopia of oral direct-acting antivirals with sustained virologic responses in the high 90s to 100%. This has been a remarkable evolution in therapies over just a few decades. And I'm going to talk about the direct-acting antivirals as we move forward. But here we can see the evolution in the sustained virologic response after treatment, that the individual continues to be negative from hepatitis C as we have advanced just a few decades from the 10s to 30% up to approaching 100% with our recent direct-acting antivirals. Now, to really understand these direct-acting antivirals, we must understand the life cycle of the hepatitis C and therefore the opportunities for impact of direct-acting antivirals. So as hepatitis C is endocytosed, it is uncoated, and the RNA is then translated in the pol and the proteins processed. The RNA is then replicated. And with this replication and protein translation, we have the building blocks for viron reassembly. The viron is in fact reassembled and exocytosed and released for further infecting of cells. It is at all these locations in the pathway that direct-acting antivirals can in fact be targeted. And I would draw your attention to this figure where the NS3A protease inhibitors are targeted to that translation and protein processing step. The NS5A inhibitors to the viron assembly. And RNA replication is targeted by the NS5B polymerase inhibitors, of which there are quite a few drugs that have been studied, and some have reached the level of approval. These drugs have changed the face of treatment not only because of their effectiveness, but also because of their tolerance. So here's some of the earlier pediatric trials of some of these drugs and their combinations. So sofosbuvir in combination with ribavirin, ledipasvir with sofosbuvir. And as you can see, these are very effective drugs at decreasing viral replication. If we start an individual on drug at week 2, you can see for either of these combinations, the percentage of patients who no longer have detectable RNA is approaching 80%. By week 4, it's in the high 90%. And by week 8, it is 98 to 100% undetectable RNA. And these are individuals who had hundreds of thousands, if not millions, of international units per milliliters to start. If we look at the sustained responses after treatment, week 4 after treatment, week 12 after treatment, which is traditionally the sustained virologic response at week 12, it is 97 to 100% sustained response. Incredible effectiveness in comparison to the interferons. Furthermore, these are oral medications. And if we look at the side effect profile, and this is in young children ages 6 to 11, treated in this case with 2 direct-acting antivirals, ledipasvir and sofosbuvir, you can see that under 20% of individuals had headaches, fever, abdominal pain, vomiting, diarrhea, cough, fatigue. I will draw your attention to the fact that these are studies in 6 to 11-year-olds where these symptoms are very common with intercurrent illnesses. So these are really well tolerated, and the side effect profile is comparable to that of the placebo group. So what do we now have approved for children? Well, we do have the original interferon and ribavirin, although that's grayed out because that certainly would not be the recommended treatment at this time. Pegylated interferon and ribavirin, 2 forms, they were approved in the early 2000s for ages 3 and 5 respectively. They are available. But we now have a number of direct-acting antivirals, and these are now the recommended therapies. These were approved recently, 2017, 19, and 20, for ages 3, 6, or 12 and older, depending on the drug combination. So to look at specifics, here is a chart of the currently approved direct-acting antivirals with the names on the left, the genotype that they are effective against. I will draw your attention to the latter 2 categories at the bottom that are effective against all genotypes. The length of treatment that is required, the dosage, and these are weight-based dosages, and then on the far right column, the formulations that are available, including pellets, that are appropriate for very small children who are not able to swallow pills, making these very effective and now available to our youngest patients. So the one downside to most of these medications is these tend to be very costly, and even with approval, there continues to be some scrutiny by some medical insurance companies, and some still require prior authorization or validation that there is high levels of fibrosis, which of course in children is not typical, and we certainly don't want to wait for, and therefore a lot of appeals are necessary. However, the recommendations are now to treat all children for which who are chronically infected and for which we have a treatment available. The question then is this cost effective? So these were some studies looking at the typical course for the wholesale acquisition cost of these agents to treat adults. And if we look at those drugs that are approved for children, you can see the wholesale acquisition cost on the far right column of the drug cost expected. And if we look at an entire course of treatment for sofosbuvir plus ladipizvir, or glecaprevir, or preventavir, you can see what the cost is for a typical course of treatment, somewhere between $26,000 US and nearly $100,000. However, we also know that if we look at the incremental cost effectiveness ratio, namely the cost for quality adjusted life years gained, it is clearly effective to treat our children as well as adults. So if we compare the cost to that waiting until the individual is 18 years of older, we know that it is cost effective to treat children over the age of 12 years. And studies, if we look at children down to age 3, will reveal the same. It is cost effective to treat children who are chronically infected as opposed to waiting until they age. So in summary, the impact of chronic hepatitis in children has physical, cognitive, and quality of life impacts on the individual as well as the family. We have very highly effective treatments that are safe and well tolerated, and they are now approved down to age 3. And as a consequence, all children should be screened for hepatitis C, and those that are infected should be treated with direct-acting antivirals. And although these drugs continue to be costly, the costs and coverage really must be improved and approved, because it is cost effective to treat these individuals, and it is the right thing to do for their health long term. So with that, I will thank you very much and end this presentation. Thank you for your attention and your care of children who are infected with hepatitis C.